a lot of disarray. So he'll be asking what is your diagnosis and how did you come to your diagnosis. That will be the only thing. So you have to substantiate. For anything for that matter, you have to think congenital, traumatic, infective, inflammatory, neoplastic and degenerative. These are the only causes. Say congenital, present from birth. Trauma, obvious trauma history should be present. Inflammatory bar infective. Then patient will have signs of inflammation. Degenerative and then malignancy. These are these causes. Then you come to the specific things. So today I thought I will discuss a few basics things I think which might have been taught by your orthopedic professors here. So what's the difference between a fracture in a child and an adult? No, that's the layman's answer. Yeah, somebody told the answer. What's a green stick? This is a green stick. This is a green stick. So how does a green stick break? It will just bend, break and then it will just peel off. So you get an incomplete fracture in a child and a complete fracture in an adult. Why is it so? Because the periosteum is very thick. So you will be asked, so some malunion, non-union is kept for you. So you will be asked what is the complication of that fracture. For any fracture you think like this, acute complication and late complication. What's the acute complication? No, it's obviously bleeding, yeah? Bleeding. So that's an excellent answer. So what's the blood supply to the bone? No. How many? What are the two sources of blood supply to the bone? Yeah, you have the periosteal blood supply and the endosteal blood supply. 2/3 of the blood supply comes from the periosteum because the muscles bring in the blood supply. 1/3 comes from the endosteum. So what happens when the bone breaks? Then obviously there is disruption of the endosteum and periosteal blood supply. There will be hemorrhage and shock. Okay, that's it. Then you have to look for the local complications. One of the complications which present will be a nerve injury. Name one fracture which can present with nerve injury. Colles fracture, which nerve injury? Yeah, supracondylar fracture. So what's a Colles fracture? I'll go from your side, yeah. What's a Colles fracture? Yeah. Is it enough? Suppose you fall down and sustain that injury. It's an extra articular fracture. Will you sustain that injury? Will it call Colles fracture? Then? Yeah, it's a fracture which occurs in an elderly osteoporotic at the junction of the relatively aortic and relatively cancellous bone to just roughly around 1.5 centimeters from the articular surface with the displacement such as you will be asked that question if a malinated Colles fracture is present. What are the displacements you find in a Colles fracture? What are the 6 displacements you have? The dorsal displacement, dorsal tilt, lateral displacement, lateral tilt, supination and or impaction. Displacement of a fracture is always said in relation to the displacement of the distal fracture. Okay. So here comes next question. What is osteoporosis? Yes, correct. Decrease in the bone mineral density by 2 standard deviations for age and sex matched control. You can have osteoporosis. So age and sex matched control. How do you classify osteoporosis? Then divided into primary and secondary. Primary is again divided into. Come on. Yeah, right. It's type 1 and type 2. Type 1 is postmenopausal. Type 2 is senile. And suppose a young patient develops a fracture. What's the pathological fracture then? Fracture occurring in a diseased bone following a trivial injury which otherwise would not have caused a fracture. So whenever you find a pathology, it always get a history. Was it a significant fall, road traffic accident or a high velocity injury? Significant fall. Obviously a fracture will develop. So insignificant falls producing a fracture in otherwise normal bones. When it's a diseased bone, it is called pathological fracture. What are fragility fractures? I was discussing about osteoporosis. What is osteoporosis? Right? It's a condition where the bone mineral density is reduced by 2 standard deviations, characterized by 3 things. What are 3 things? Microarchitectural deterioration. Imagine a pillar. The pillar is how is a pillar made up of? You have the iron rods, the small kettugambi. Inside that you put the concrete. So what happens in osteoporosis? The cement and the matrix will disappear. Then the kambi will start appearing. Then the kambi will start crumbling and you get a fracture. Those fractures are called fragility fractures. What are fragility fractures? Examples? Oh, what are examples? A Colles fracture is good. Then you have the fracture neck of femur, then you have the trochanteric fracture and the vertebral compression fractures. So from there we will shift on to the hip fractures. How will you classify hip fractures? I will stop in 20 to 30 minutes, then we will have the case. What hip fractures? What is hip fracture? Classify hip fractures? Yes? How do you classify hip fractures broadly? According to the age, okay, that's good. Then? Yeah, anatomical, how? Intracapsular and extracapsular. What's the peculiarity of intracapsular fracture? Yeah, what's the complication of intracapsular fracture? Non-union and avascular necrosis. Why that fracture will not unite, intracapsular fracture? Yeah, precarious blood supply, absence of cambium layer, then synovial fluid will bathe away the clot, and then synovial fluid contains an angiogenic inhibiting factor which inhibits the clot formation. For these reasons, intracapsular fractures will not unite and its complication will be non-union and avascular necrosis. I am saying this because one of the OSCE questions will be your intracapsular fracture, what is the complication? Got it? Then what about extracapsular fracture? What? Correct? What? ORIF? No. I told you these are fragility fractures which occur in elderly patients. You don't expect the patient to live for more. Suppose in young patients you go for an emergency fixation because always a native head is better than a replaced head. Older patients you do a total hip is not the answer. You do an arthroplasty. You can say arthroplasty. You do a you replace one half of the joint. That is called hemiarthroplasty. Suppose the acetabulum is also diseased. You do a total hip arthroplasty. So that's intracapsular fracture. Now, what about extracapsular fracture? It's a trochanteric fracture. It's outside the capsule. What's the peculiarity of trochanteric fracture? It's outside the capsule. It's metaphyseal. So that fracture has a tendency to unite. So that complication will be malunion. 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 What's the normal neck shaft angle? 130 to 140. 145. Okay. So instead of being like this, it becomes like this and the coxa vara. So the complication of an extracapsular fracture will be malunion, coxa vara, and secondary osteoarthritis. That's the complication of extracapsular fracture. What's the treatment of a fracture? What's the principle of treating a fracture? Any fracture for that matter. So what's the principle? Principle will be to maintain the length, alignment and rotation. Immobilizing one joint above, one joint below, most of the fractures will unite. Maintaining the length, alignment and rotation. So here's an extracapsular fracture. You maintain the length, alignment and rotation and you fix it with and allow the fracture to collapse using a lag screw and you stabilize with an intramedullary nail. That's called proximal femoral nailing, or you can put a dynamic hip screw wherein you put a screw into the fracture site and buttress it with a plate. So dynamic hip screw and intramedullary nailing, proximal femoral nailing. That's intracapsular fracture. We are discussing about Colles fracture, right? So what are the complications of Colles fracture? Will it be non-union or will it be malunion? Malunion. So what is malunion? Yeah, fracture uniting, not united, fracture uniting in an anatomically unacceptable position is called malunion. What's the treatment of malunion? Oh, fantastic. You have seen dogs moving around here. ഒരു കാലൊക്കെ ഇങ്ങനെ മുണ്ടി മുണ്ടി പോണ കണ്ടിട്ടില്ലേ പത്രിക അവരെല്ലാം ட்ரீட் பண்ணுவோம் பண்ண மாட்டேன் ஏன் ட்ரீட் பண்ண மாட்டேன் எதுக்காக ட்ரீட் பண்ணணும் அப்படிதான் unless it interferes with the function or if it is cosmetically deforming, otherwise you will not touch a malunited fracture. Okay, so not all malunions require treatment. Okay, I'll come later. So malunions are treated only if it is functionally compromising or it's cosmetically deforming. So then comes the answer. You do an osteotomy. What's osteotomy? Creating a factor is not osteotomy. Intentional surgical breaking of the bone is called osteotomy. You break the bone, realign it and then fix it. Okay, then what are the two things necessary for fracture healing? Bone has been broken into two. And biology, and that is biology. Second one is
stability. So how will you classify non-union? Yeah, very good, very good. So the two things necessary for fracture healing are, one is biology, second one is stability. When biology and stability is lost, it results in what? Atrophic non-union. When biology is preserved but the stability is absent, it will just cauliflower but unite pannavate. That is hypertrophic non-union. So treatment of, what's the treatment of atrophic non-union? Here biology and stability is lost. So you provide biology as well as stability. How will you provide biology? Okay, bone grafting. Next question will be, what are the functions of bone graft? What are the functions of bone graft? So two things, one is biology and stability. Stability is provided by an internal implant, by a nail or a plate, or an external fixator, or by a plaster. But biology provided by bone graft. What are the functions of bone graft? Yes, anybody? Anybody? Strength of the bone, yeah. Osteoconduction, conduction, osteoinduction, and osteogenesis. So biology and stability has to be provided in the case of non-union. How will you define non-union? What is non-union? Is non-union, if the case is present, it will be kept for examination. What is non-union? Fracture has not united for the stipulated time for that fracture to unite. Normal time for that fracture to unite, which roughly for the upper limb it is 4 to 6 months and lower limb it is 6 to 9 months, and there is no clinical or radiological evidence of healing for the past 3 months. What's the clinical evidence of healing? What happens when the bone breaks? There will be pain, tenderness and abnormal mobility, which is painful. Pain, tenderness and painful abnormal mobility. In non-union, the process healing has come to a standstill. What happens there? There will be painless abnormal mobility at the fracture site and absence of transmitted mobility. What do you mean by transmitted mobility? You give mobility to one end, it will be transmitted to the other end. You give rotation movement. You give rotation here, that means it will pass up to the elbow. Suppose that non-union here, that force will be dissipated at the non-union side. That is clinical evidence of healing. What are the radiological evidence of healing? Callus formation, and there will not be any fracture line, and there will be bridging of the trabecular pattern. Okay, so that is roughly around. That's roughly around. No, so I will discuss a few cases which are going to be presented. One is non-union. So for non-union, you have to think whether it's hypertrophic or hypertrophic, and then you provide biology as well as stability. Malunion, this later only when it is cosmetically disfiguring or functionally compromising. In that case, you do a osteotomy and realign. Okay, so that's malunite case will be kept for the examination if it's available. Okay, then what else? Fragility fracture. Now we will discuss about something connected to nerve. You will be kept if there's a case of median nerve. Suppose the patient is having tingling and numbness in the hand. Patient Tamil kaiyil peruthu irukku. What will be the diagnosis? What are the things which will come to your mind? Probably nerve compression. Then what will you think? You think about the switchboard and the bulb. The problem could be in the switchboard, problem could be in the wire, problem could be in the bulb. So what is the problem in the switchboard? Brain, you think for you are going to a transformer. She's going to a transformer. Brain is a transformer, right? Forget about the transformer. Switchboard. A patient can have what? Cervical spondylosis or some myelopathy. Then you have the plexus injury. That's the wire. Then along the wire, the patient can have a compressive myelopathy of the median nerve. Then bulb injury, some function. So what? Suppose the patient is coming with tingling and I say in the moon varil mattum thane peruthu. No, that's the first thing. You should never say radial nerve. You should not make those mistakes. So it is median nerve injury. What's the condition? So okay, then you will be asked what are the causes of carpal tunnel syndrome? What are the causes of carpal tunnel syndrome? Yeah, primary. Yeah, it's idiopathic. That's idiopathic. You had that in mind, right? Then other things will be any condition producing. So once it is primary, it's always secondary next, right? So any condition producing a fluid overload, as in edema as in a pregnancy, myxedema, hypothyroidism, all those things can produce. So you have to rule out hypothyroidism. Then you look for malunited fractures. What injury in the wrist can produce median nerve injury? Collis fracture. Collis fracture produces a dorsal displacement, dorsal tilt, lateral displacement, lateral tilt, supination and or impaction. But it's smaller. What's the counterpart of Collis fracture? Mr. Smith fracture. So you get a garden spade deformity. So that can, then again, what small bone injury can produce carpal tunnel syndrome? Lunate dislocation. Forget about it. So you will be asked, how will you diagnose median nerve injury? You will be asked about the muscles supplied by the median nerve, muscles supplied by the ulnar nerve, all those things you should know. What in the autonomic area of nerve? Yeah, that part of the dermatome which is exclusively supplied by the bone is called, nerve is called the autonomic nerve. Radial nerve, which part? No? There you lost it. Radial nerve, tip of the finger. Yeah? First web space. Median nerve? In second one, ulnar nerve? Little finger, volar part of the little finger. That's the autonomic area. Then you look for you have to look for the motor, you look for the sensory and the pseudomotor. You look for other autonomic dysfunction. So carpal tunnel syndrome is one case which can be. Next case will be a nerve injury. Nerve injury. For example, sir showed a case of wrist drop. That you have to know it's radial nerve injury. What about this one? The patient is having like this. That's which condition? The patient is having like this. Complete clawing. It's not this finger alone. This finger alone, ulnar clawing. This one, complete clawing. Cause of this one, ulnar nerve. Commonest cause? Commonest cause producing complete claw hand. Leprosy, yes, fantastic. Good. Shoulder dislocation, no. Thing is tunica palsy. Both these nerves together. Patient may have wrist drop also. So you must know ulnar claw hand, pointing index, wrist drop. Then you will be asked how will you classify nerve injuries? പിന്നാടി വാ സുന്ദർലാൻഡിക്ക് മുന്നാടി ഒരു ക്ലാസിഫിക്കേഷൻ ഇരിക്ക് സഡൻ ക്ലാസിഫിക്കേഷൻ വാട്ട് ഇസ് സഡൻ ക്ലാസിഫിക്കേഷൻ neuroapraxia then axonotomesis and neurotomesis. What's the difference between what is neuroapraxia? It's a temporary physiological block in the conduction of the nerve. What's the prognosis? Good, it will just recover. Examples of neuroapraxia? Right? You said. Crutch palsy, good. Crutch palsy and then Saturday night palsy. That will recover. What is axonotomesis? The sheath is preserved but there is internal demyelination. So what is neurotomesis? Complete transection. So what happens when the nerve is completely cut? What happens to the proximal part? What happens to the distal part? Yeah, the proximal part will just grow, try to grow. And the distal part will be ready to receive the proximal sprout. So you get a Valerian degeneration. These things may be asked in nerve injury. You should know those. I am just touching through the few things which randomly come to my mind. So you get Valerian degeneration in the distal part and the proximal part you have the nerve regeneration. So nerve will try to grow and the other one will put a bed for the receiving the sprout. So you get a neuroma at the proximal part and a glioma at the distal part. So you will be asked what the Tinel sign is. What's Tinel sign? Yeah. So you tap along the course of the nerve and see whether it's advancing from proximal to distal. That's proximal to distal, whether the Tinel sign is progression, tingling along the nerve. That is Tinel sign. So what's the treatment of nerve injury? Suppose the patient is present with a wrist drop. That depends on the time of presentation. For any nerve injury, for your level, we can wait up to 4 to 6 months or 6 to 9 months. If it is not recovering, if you think it is not injuring, you have to do a primary repair or a fascicular repair, end-to-end repair. Forget about that. It's not recovering. It is, and after 9 months, what will you do? Correct. Tendon transfer. Just keep in mind, you have to do tendon transfer for the wrist drop. So that's the importance when a patient presenting with a wrist drop, you have to assess both the median nerve and the radial nerve. Now coming to the tumor part, a patient present with a bony swelling, a 10-year-old boy. So what are the parts of the bone? Yeah, epiphysis, Metaphysis, diaphysis and the physis. What is the, we have physis, what is physis? Physis? It's a growing end of the bone. So you'll be asked what are the layers of the physis. What are the layers of the physis? It's a growing part. Zone of resting cartilage, zone of hyperplasia, hypertrophy and degeneration. So that's a part where you get what? Growth. Now, so from there you may be taken up to how will you classify epiphyseal injuries? Who classified epiphyseal injuries? You should know. Salter and Harris. You should read, I'm not going to tell you, Salter and Harris. Refer about that. Okay. Salter and Harris classification. So where were we? We're discussing about bony swellings. So whenever a patient presents with a bony swelling, the first thing you look for will be the age of the patient. Any patient for that matter, age of the patient. Then you look for the site. Site. What's the site? Site will be epiphysis, metaphysis, diaphysis. What's the commonest metaphyseal swelling? Primary swelling. Metaphyseal. It could be a benign swelling or a malignant swelling. You're thinking about malignancy. Metaphyseal. 10 to 14. Osteosarcoma. Metaphysis, osteosarcoma. Ewing sarcoma, where does it occur? Diaphysis. Age group will be slightly older. So you have to, when a patient presents with diaphyseal swelling in a 10 to 20-year-old child, you think of three things. So any swelling whenever you find an abnormality in the X-ray, you think what's the lesion trying to do to the bone? What is bone trying to do to the lesion? It could be infection, it could be malignancy, it could be fracture. What's the lesion trying to do to the bone? What is bone trying to do to the lesion? If it's a benign lesion, the body will try to contain it. You get a sclerotic rim. It's a malignant means it outgrows body's defenses and it will just spread. So you get a geographic or a moth-eaten appearance. The same thing can be presented in infection. Infection is a fight between bodies, resistance and the virulence of the organism. If the resistance is good, body will try to contain it. What is that called in a bone? A patient present to a 10-year-old boy presenting with pain in the upper end of tibia. On examination, you find a sclerotic lesion. A sclerotic lesion. Osteodystroma is not that. What is Brody's abscess? Brody's abscess. So what is osteomyelitis? We'll go like that. What is osteomyelitis? Yeah, osteomyelitis, if it is present, it will be kept for examination. How will you diagnose a case of osteomyelitis? You have a picture? Picture on osteomyelitis picture on. Okay, how will you diagnose a case of osteomyelitis? History of trauma, compound fracture treated by some method. Now presenting discharging sinus. On examination, you find a sinus and thickening, irregular thickening of the bone. Suppose there is sprouting granulation in the mouth of a sinus. What does that mean? There's a sinus, there's sprouting granulation in the mouth of a sinus. What does that mean? New bone. Bone reacts to injury only by forming new bone. The new bone formed in fracture is called? Cona. New bone formed in fracture is called? Osteophyte. What happens? How does the bone heal? Yeah, callus. The new bone formed in fracture is called? Callus. The new bone formed in infection is called? Involucrum. The new bone formed in tumor is called? Tumor osteoid. Bone can react only by forming new bone. So it's the nature of the osteoid which determines what the pathology is. Now we are discussing about the swelling in the bone. So we are discussing about osteomyelitis. So it is a sclerotic lesion in the proximity to Brody's abscess. That's a metaphyseal region. Suppose the patient is complaining of pain in the diaphyseal region. 10 to 20-year-old boy. Diaphyseal. Diaphyseal means mid shaft. So anything for that matter, when you are asked why or how, you think a congenital cause, a traumatic cause, inflammatory cause, infective cause, degenerative cause, or neoplastic. Congenitally solved. There is no trauma. What could it be? Trauma. It's not working. Sorry. Trauma. Yeah. Congenitally south. So trauma. A military recruit recently recruited, strenuous activity complaining of pain in the midshaft of the tibia. It's a stress fracture, one possibility. Then you have the congenital out. Then trauma. Then infective. What infective? Diaphyseal swelling. On end of the patient is having pain, swelling. TB. If you ask, tell me TB, I'll have to shift to TB then. so what is it? Have you heard of subacute sclerosing osteomyelitis of Gare? So chronic osteomyelitis, wherein you get remissions and exacerbation, but there won't be any sinus. So diaphyseal swelling differential diagnosis will be one, a stress fracture. Second one will be subacute sclerosing osteomyelitis of Gare. Third one will be an osteoid osteoma. What's an osteoid osteoma? An osteoid osteoma. Third one will be, fourth one will be Ewing sarcoma. So you have to distinguish between Ewing sarcoma and osteoid osteoma. So what's the profile of osteoid osteoma? History like 10 or 20 year old complaints of pain and swelling in the diaphyseal region, pain relieved by aspirin, and there is night pain. That is the typical history of osteoid osteoma. Can you hear me? So diaphyseal swelling, night pain, pain relieved by aspirin. That is the typical history of osteoid osteoma. What will be the history in Ewing sarcoma then? Ewing sarcoma is one malignancy with systemic manifestations. There will be periods of remissions and exacerbations, just like chronic subacute sclerosing osteomyelitis. So remissions and exacerbations. And what will be the X-ray finding in Ewing sarcoma? Onion peel. Ulli, cut the ulli, see the inside. That's onion peel appear. That's osteoid. So here we are in a diagnostic dilemma. So what will you do? Diagnostic dilemma. So you need to, one of the treatment is this side, fracture. Another treatment? Infection. Other one will be a tumor. Three different directions. So you'll have to distinguish between these three. How will you distinguish? Correct. Why? What investigation do you want? Yeah, you need a tissue diagnosis, biopsy. What are different types of biopsy you know of? You can do a fine needle aspiration cycle, which is not possible in the bone unless it is a soft tissue extension. Then you can do a core biopsy. What's the needle called? Jamshedi needle. It consists of two parts, a stellate and outer trocar. Trocar and outer, trocar and the stellate. You plunge in the trocar and then you histopathology examination, and you get the diagnosis of whether it's tumor or infection and treat accordingly. Suppose osteosarcoma. Biopsy came as osteosarcoma, metaphyseal swelling. What's the treatment? A case if present will be kept for examination, swelling of the proximal tibia or proximal humerus. What's the treatment? Biopsy came as osteosarcoma. The swelling, patient presents swelling of the upper tibia. You will be asked what's the diagnosis, how will you manage? You have differential diagnosis of osteosarcoma versus an infection. So you need to have a biopsy. Biopsy came as osteosarcoma. From now on, what will you do? Excellent. Yeah. You don't go straight away for excision. You give neoadjuvant chemotherapy. What is neoadjuvant chemotherapy? It's a chemotherapy given before the surgery. What does neoadjuvant chemotherapy do? It shrinks the size of the tumor, makes the tumor resectable, and takes care of the neovasculature and takes care of skip and satellite lesions. What do you mean by skip lesion? What do you mean by satellite lesion? Within the compartment is called a skip lesion. Other one satellite is outside. So the neoadjuvant chemotherapy. Then you do limb salvage surgery. What is limb salvage surgery? Previously, most of the tumors were treated by amputation one joint above. So you are safe, but the patient is alive. But it's no longer acceptable now. So what is limb salvage surgery? Save the limb, yeah. It's a subamputative, wide en bloc resection of the tumor, attaining adequate surgical margins without compromising the function of the limb. A subamputative, wide en bloc resection of the tumor, attaining adequate surgical margin without compromising the function of the limb. So you have resected the tumor, and what will you do with the gap? You have to reconstruct the gap. That is limb salvage. So either by a prosthesis, bone graft, or whatever. Then what will you do? The specimen is sent for histopathology examination. What do they look for? What do they look for? You have got a diagnosis, but you have resected the tumor and sending for examination. Why do you want to send it for another examination? One is for marginal clearance. Yes, good. Then look for tumor necrosis. Hughes criteria. 0 to 25, 25 to 50, 50 to 95, 90 and above 95. If the tumor necrosis is good, you give less adjuvant chemotherapy. Adjuvant chemotherapy is the chemotherapy given to the patient after resection. So that's clear about osteosarcoma. Now coming to benign tumors, we are discussing about osteoid osteoma. We are in doubt whether what's the differential diagnosis? Subacute sclerosing osteomyelitis versus an osteoid osteoma. So here you'll have to, who classified bone tumors? WHO. WHO has, yeah, since she has said WHO, let us ask about what's WHO classification of bone tumors. WHO classification is basically a classification wherein you take the tissue of origin. It could be divided into bony, cartilaginous, hematopoietic or a fibrous. Okay, so bone tumors will be, again, that's the WHO classification. For all clinical purposes, it is divided into benign and malignant by Enneking. Enneking classification, benign. Benign is again divided into benign latent, benign active and benign aggressive. Benign latent tumor will be a simple bone cyst. What is a simple bone cyst? Simple bone cyst. Simple bone cyst presents at a younger age group, usually in the metaphyseal region, and you get a fallen leaf sign. What is a fallen leaf sign? Bone piece inside this thing. So treatment is, it just heals by like that. That's a benign latent lesion. Benign active lesion will be osteoid osteoma. Whereas when you get a pain swelling in the diaphyseal region with night pains, it's an active lesion. Then you have the benign aggressive lesion, GCT. What's the peculiarity of GCT? Tell me 10 sentences about GCT. Think about EASE, eccentrically placed, expansile, epiphyseal lesion with eggshell crackling. Eccentrically placed, expansile with eggshell crackling. Epiphyseal swelling. What's the treatment of a giant cell tumor? Curettage matra madhiyo. You have cavity, you are curettage. Simple curettage will not be sufficient because it is a benign aggressive tumor. If you leave behind something, it will recur. So benign aggressive tumor. So extended curettage using special instruments, bone burr or special scoops, you curettage or curate all the corners of the bone and then you reconstruct the defect with a bone substitute or a bone graft. That is, and that's extended curettage. So eccentrically placed, expansile, eggshell crackling, epiphyseal, extended curettage, and in expendable bone you can excise. Expendable bone means, example, a lesion occurring in the upper end of fibula. Benign, latent, benign active, benign aggressive. Now, one case which will be kept for examination will be an osteochondroma. What is an osteochondroma? It's a benign cartilaginous tumor arising from the metaphyseal region away from the physis. So, what will be the clinical picture like? A swelling, bony heart swelling. How will you classify osteochondroma? Into solitary and multiple. Whenever you find a single osteochondroma, feeling sleepy? I have come all the way from Tirundaram to just have a word with you and you are sleeping. So whenever you find a swelling anywhere in the body, look for multiple swellings. Why do you want to look for multiple swellings? Hereditary exostosis, they have got a malignant potential. So osteochondromas are divided into sessile osteochondromas and pedungulated. There will be a stalk. So what are the if osteochondroma is present, you will be kept for examination. So what are the causes of pain in osteochondroma? One, a fracture of the base of the pedicle. Second one, an increase in size, malignant transformation, pressure effect on the nerves, bursa formation, adventitious bursa formation. These are the causes of pain in osteochondroma. What's the treatment of osteochondroma? Extra, that's the key word. That's the key word. Extra periosteal, even it's never subperiosteal. Extra periosteal excision of the tumor. That is osteochondroma. So can you stop here or we'll have the cases? I know. I can go on and on and on. So we'll have the discussion of the cases. So there are 4 cases to be discussed, right? Okay. So we'll discuss after that. And I have another presentation also. So one more thing. What are the causes of non-union? What are the causes of non-union? What are the causes of malunion? Correct? So there, whenever you are asked like this thing like this, local factors and systemic factors. Systemic factors means local should be again congenital, osteogenesis imperfecta. inflammatory, also infective pathologies, then degenerative, then debility, malignancy, chronic liver disease, HIV, alcoholism, all those things are systemic. Think about the local causes. Yeah, 6 I's: inadequate reduction, inadequate immobilization, intact fellow bone, interposition of soft tissue, infection, and inadequate blood supply. Have you heard about this? There are local factors and systemic factors. Systemic factors, old age, debility, all rubbish things. Now, local factors are surgeon related and patient related. Surgeon related, inadequate reduction, inadequate immobilization. Patient related, inadequate blood supply, infection, interposition of soft tissue, and inadequate blood supply. So these are the causes of. And what about malunion then? Abnormal pull of the muscles, abnormal immobilization. Those things will result in malunion. So malunion if present, it will be kept for examination. Non-union will be kept for examination. Nerve injury will be kept for examination. Swellings, these are few swellings. We will discuss that the 4 cases and then we'll stop.